Welcome to the final segment of It's a Whole New World, our gene therapy segment. This is the last segment of the year. We're back in 2025 with 12 new segments for you. But here at the end of this year, we kind of wanted to recap some of the highlights. We've talked about a lot of things on this segment that I think have been really well ranged in their topics. We've talked about the difference between hemophilia A and hemophilia B gene therapy. There are some fairly significant differences. We've talked about reimbursement. We've talked about how our hemophilia treatment centers are set up to administer gene therapy, to reimburse gene therapy. I was actually encouraged by those conversations with our HTCs. We talked about the myths around gene therapy. There are so many big myths that are going around about this particular treatment. We talked about the unique trial design of Hemgenics in particular. It actually was a fantastic segment. If you missed that one, please go back and look at the unique trial design of Hemgenics. And we also had the story of the first commercially dosed patient for gene therapy for hemophilia B, a patient out of Green Bay, Wisconsin. We heard that story from the Buxton family. We heard from Mason, who was the patient that was dosed, and his dad, Jameson, and his stepmom, Andrea, who we're going to hear from a little bit today. So I wanted to just kind of put together some highlights of what the segment was, do a little bit of a wrap up before we head into 2025. As a reminder, this segment is brought to you by CSLBehring, a global biotherapeutics leader focused on serving the rare disease community by providing innovative therapies. They now have a first-of-its-kind treatment for hemophilia B. To learn more about this treatment option, visit beyondhemb.com and download the B Support app from the App Store or Google Play to stay up to date on relevant information and manage your treatment journey. So, y'all, one of our guests this season was Dr. Stephen Pipe, a pediatric hematologist from the University of Michigan. And we asked Dr. Pipe to give us an overview on the paradigm shift in treating hemophilia nowadays. And as usual, he gave a fairly elegant response.
I would say at best, what we can offer patients is a once weekly IV infusion in order to provide adequate prophylaxis to prevent breakthrough bleeding. Now, when I say adequate, meaning up until now, there really hasn't been anything better than factor IX replacement. So how good has factor IX replacement been? Well, we know that patients still have breakthrough bleeds. They still have breakthrough bleeds into joints. We know they still miss school. We know they still miss work. We know that chronic joint debility is still a feature of patients who've been on prophylaxis their whole lives. We know a significant proportion of patients report chronic pain on a daily basis. So when we say factor IX replacement is adequate, that's because up until now there really hasn't been anything to offer better. So this is a paradigm shift. Instead of having to replace the protein over and over and over again, we're going to take a different approach here, and we're going to have the patient's own liver be the factory that makes the factor IX. And so we've had the gene, we've cloned the gene for factor IX, decades ago. That's how we've been making all these recombinant clotting factors from that gene. But that's sitting in a factory somewhere in a big bioreactor making protein. Why don't we get the gene into the liver and have the patient's own liver make the factor IX for them? This, in concept, could be a single treatment event. And then once the gene is there, the normal protein machinery of the cell, of the liver, will be able to make the protein in perpetuity. So the challenge was, how do we get that gene into the liver efficiently and durably so that from a single treatment event, we can expect their liver to make factor IX, for good from that point forward. So we've spent really the last 30 years looking at all different options of how to deliver factor IX to the liver. And the process or the procedure, if you like, that seems to have had the best risk-benefit profile for the hemophilia community is using these non-pathogenic viruses called adeno-associated virus. Now, we're not actually using the whole virus, the active virus, even though it's a virus and we're kind of nervous about viruses these days, right? But this is a non-pathogenic virus, which means it doesn't cause any disease in humans. Plus, we aren't leaving the viral genes within this vector. We're stripping those out, and it's replaced with what we call the transgene, which is just the factor IX clone gene, and then a few extra elements so that it can remain stably inside the cell once it's delivered. And also, so it only gets expressed in the liver. So we include what are called genetic elements, promoter elements, so that once it gets into the cell, only the liver cell can read the code and make the protein.
I told y'all he was elegant. I told y'all. Most of us have now heard how gene therapy works, but I think it helps to continually have it broken down because it's such complicated science. And every time you hear it, you might gain a new insight. So thank you, Dr. Pipe, for that. Now, on to some of the things that we discussed on this season was the differences between hemophilia A and hemophilia B gene therapies. And I spoke with Dr. Mark Redding about this topic. There is obviously a difference between the hemophilia A gene therapy product and the hemophilia B gene therapy product in data, efficacy, all of those words that we use. Tell me why. Why is there such a difference? Why are we seeing different outcomes?
Super good question. There's a lot to talk about, but I think, the biggest difference so far in the currently available gene therapies that we have and the things that are currently being studied in the sort of late phase clinical trials, the biggest difference between hemophilia A and hemophilia B gene therapy seems to be durability. In other words, how long do the factor levels stay up? So for factor IX, hemophilia B gene therapy, it seems that whatever response you get, it seems to be stable over time, at least out to 3 years or so. With the hemophilia A gene therapy, what we're seeing is the factor levels tend to fall off over time. They don't seem quite as stable.
What's the cell that makes factor VIII?
So factor VIII is normally made it's made in the liver, but it's in a different cell, not the hepatocyte. It's made in a cell called the sinusoidal endothelial cell. So the endothelium is the cells that line the blood vessels and the sinusoids, which are little vascular spaces in the liver. That's where factor VIII is made. So a little bit different place than factor IX is made. And both the currently available gene therapy treatments deliver the gene therapy to the hepatocyte. So into the organ, but not to the exact same cell type that normally makes factor VIII. And that probably has a fair bit to do with why it looks a bit different.
So I mentioned in the intro, one of the highlights of our segment this year was we had the story of the first commercially dosed patient for hemophilia B gene therapy. Andrea Buxton is a nurse practitioner at the Hemophilia Outreach of Wisconsin Hemophilia Treatment Center. And not only was she the patient's nurse practitioner, she was also his stepmother. Her story is awesome, as is Mason's, who is the patient, of course, but that's not actually what we're highlighting today. Today, I wanted you to hear from Andrea a little bit about the personal decision that each patient is making or contemplating as they're thinking about their treatment plans going forward.
I think you're always going to have patients that are a better fit, and it's going to really come down to what are the patient's goals and values. The patients, I think it should be available to any patient, and they should all know what it is, and they should all be aware of what it is. And I think as providers, it's our job to make sure we're educating on all new treatments, right? Not just gene therapy. But I think some patients are going to say, it's not the time for them, and that's okay. They might want to wait a while, or maybe they're content with their quality of life in regards to their prophylaxis schedule, their, maybe lack of bleeds currently. And those patients aren't going to make that choice, I think, to travel down the path. But I think that there should not be any patients that should be excluded from those conversations. I will say our both young men actually that we dosed here at the Hemophilia Outreach Center were not very compliant with their prophylaxis. And they're very willing to admit that. So there's been discussions, I know, amongst other healthcare providers in regards to if they're not compliant now, are they going to be compliant with that follow-up? Maybe we don't want to take that risk, but I think those are actually the patients that you will see benefit the most from gene therapy. So I do think it is our job to be able to, or to be offering this as a treatment option for a patient.
So, in our conversation with Mason, one of the reasons that he decided to administer gene therapy was he had a fairly significant fear of needles. And that is a real thing. You would think that hemophilia patients would become desensitized to it over the years. And it's just not how the human spirit works at times. And so we hear from Andrea, I think, a little bit about her experience with Mason, his fear of needles, and his decision to move forward with administering gene therapy.
You would think like he'd be kind of desensitized to that after all these years of the pokes that he had, but he just never could. So I think that, a lot of the patients pursuing maybe the gene therapy have that same, maybe fear of needles, or they just, they're younger, and we know that younger people generally are not the most compliant with medications. And I think, or have always thought that ironically, it's, males that suffer from a bleeding disorder the most, right? We've got definitely a larger population of severe to moderate hemophilia males than we do females, but males generally are a little less compliant. In younger age, we have studies that show that just their health in general, they kind of feel like maybe they're almost invincible to having a significant bleed. And then unfortunately, they don't do their prophylaxis and they have a bleed, and they're reminded that that's right, I have hemophilia and now I have to treat, or I'm going to have further problems down the road.
So those are my highlights. Those are my highlights for y'all. We're so excited to be back in 2025 to offer new topics about gene therapy, to push a little bit deeper into the space, and to kind of learn not only about the science, but also the conversations that are around this new fantastic treatment, because it is a whole new world. Again, this segment has been brought to you by CSLBehring, which has a first-of-its-kind hemophilia B treatment. Visit beyondhemb.com or download B Support wherever you get your apps for more information.